Assalamualaikum, Dr. Santosh, Assistant Professor, Nephrology, JSMU. Today we discuss on the nephritic syndrome as we earlier discussed on the nephrotic syndrome. This is the nephritic syndrome. So, the nephritic syndrome is a clinical syndrome defined by hematuria, red cell cast, hypertension, oliguria, decreased urine output less than 400 in 24 hours, and uremia, increased urea or increased creatinine in the serum is called uremia, proteinuria less than 3 gram in 24 hours. Basically, more than 3.5 or 3 gram in 24 hours is the definition of the nephrotic syndrome. Less than 3 gram, more than 1 gram is called non-nephrotic range proteinuria, which appearing in the nephrotic syndrome. So simply means the proteinuria less than 3 gram. If the more than 3 gram, it means nephrotic syndrome. Less than 3 gram is the nephrotic syndrome. Sign and symptoms: hematuria or polar current depend upon the cause. Proteinuria less than 3 gram, hypertension, oliguria, flaying pains, generally symptoms, systemic symptoms. A post-infectious 2 to 3 weeks after streptococcal throat upper respiratory tract infection. Hematuria after 2 to 3 weeks after the streptococcal throat infection or upper respiratory tract infection also indicate nephrotic syndrome. In other than the synphrengetic hematuria, it means the lesion of nephrotic syndrome is IgA nephropathy. What the meaning of synphrengetic? Synphrengetic means the throat infection along with the hematuria at the same time is called synphrengetic hematuria. If the throat infections but the hematuria appearing after the 2 to 3 weeks is most commonly because of the post-infection glomerulonephritis. In IgA, the throat infection at the same time of the hematuria is also called synphrengetic hematuria. What are the differences? Malignancy, older patients, UTI, and trauma. Okay, the causes of the nephritic is the post-infectious glomerulonephritis, as I defined, the history of sore throat and hematuria after the 2 to 3 weeks. And primary causes IgA nephropathy or Burgess disease, in which the synphrengetic hematuria, history of sore throat at the same time hematuria. And this is the presentation of IgA nephropathy, but can be present with the macroscopic hematuria. We can see the naked eye hematuria. Rapidly progressive glomerulonephritis. This is the rapidly progressive means the lesion which appearing suddenly. Patient having a no prior history of any renal related diseases. And proliferative glomerulonephritis. Secondary causes of the glomerulonephritis and Hennig swelling, purpura, and vasculitis. So the common glomerular disease presenting as the nephritic syndrome and disease association and what the serological test have been done. The post-streptococcal glomerulonephritis association, pharyngitis, emptyema, skin infection, and pharyngitis associated with the post-streptococcal glomerulonephritis. What the investigation we should do? We should do for the diagnosis: ASO titer and streptozyme antibodies. Other post-infectious disease: endocarditis, abscess, and shunt. Endocarditis associated with the cardiac murmur, which serological test to help out in the diagnosis in the blood culture and decrease C3 and echocardiography. Abscesses, blood culture, and C34 can be normal in the what the kind of abscess in the body, but the blood culture could be positive. Shunt, patient having a history of treated hydrocephalus. So hydrocephalus, we basically go for the shunt to reduce the pressure of the brain, CCSF, so in which also the blood cultures and C3 is alone. IgA nephropathy associated with the upper respiratory or gastrointestinal infections. Serology, serum IgA levels increase. Lupus nephritis can be present with the nephrotic syndrome and can be present with the nephritic syndrome. So the association multi-system features of the lupus. Lupus can involve lupus basically SLE is a basically systemic disease involvement of the multi-systemic SLE when the renal involvement, which we diagnosed on the simple test on the initially urine DR, which present shows the protein urea and RBCs and caused in the SLE patients, then we called as a lupus nephritis, means involvement of the kidney. So serology, antinuclear antibody, double-stranded DNA, and complement levels. The complement levels C3 low and C4 low in the lupus nephritis. Investigation, other urine depistic, as we discussed in last chart. The urine depistic, urine microscopy to see the red cell count, urea, creatinine, and electrolytes to see the renal functions like urea, creatinine, and electrolytes imbalance in acute kidney disease can present with a hyperkalemia. Blood, the usual plus renal screen, immunoglobulins, electrophoresis, complements, antibodies, ANA, NCA, anti-double-stranded DNA, anti-GBM, blood culture, ASO titers. These are the blood tests for the diagnosis of the nephritic syndrome. Again, renal ultrasound and gold standard is the renal biopsy for the definitive diagnosis. What is the management of the nephritic syndrome? Conservative management, medical management, and surgical management. Conservative, monitor urea, electrolytes, blood pressure, fluid balance, weight, salt, fluid restriction, treat underlying cause. Medical diuretics, treat hypertension, corticosteroids and immunosuppression according to the Lyon, and if medical treatment not treated, not response to the medical treatment, and kidney injury, should go for the hemodialysis. And patient developing CKD secondary to nephritic syndrome, then the definitive treatment again is the renal transplantations. Okay, thank you.